patient comes with weakness of hand. Okay, for example, this patient came with complaints of weakness over the left hand. So that's your chief complaint over the past 1 year. So the intended examination will be peripheral nerve examination. So peripheral nerve means it could be either median nerve injury, ulnar nerve injury, or radial nerve injury. Now, if you have sufficient time, you can do the examination for all 3 nerves. But let's say you have limited time. A bedside examination, short case. So you want to pick one nerve to examine. So what will you do? You will screen for the 3 nerves. So according to the screening, the test which is positive for a particular nerve, you do the full-fledged examination which involves look, feel, move special test for that particular nerve which is positive from the screening. But foremostly, you have to position the patient properly. So how will you do? Get a pillow and make sure the patient is comfortable. Okay, he can rest the forearm over the pillows. Okay, and also you can, this is something you can do, you can ask him to expose umbilicus above. What's the logic to this? Why do we want to expose the patient umbilicus above? So remember, at the end of the examination, we must be able to identify the nerve which is injured and the level of lesion. So you must be able to tell where's the nerve injured. So you remember, the nerve injury can come from the root itself. Okay, so in brachial plexus you have the root, so spinal root. So the nerve which supplies the latissimus dorsi muscle, the thoracodorsal nerve, and the peripheral nerves share the same origin at the spinal cord. Okay, they share the same origin. So if there's latissimus dorsi wasting, it can give a clue that the level of lesion is at the root, at the spine level. So having that done, so how will we do screening for median nerve? So ask the patient to make an OK sign. Boleh buat macam ni. Touch the tip to tip. And tengok full tip. Okay. So patient is able to do OK sign. Okay, OK sign is only possible if the median nerve is intact. Okay, it's because the anterior interosseous nerve, which is a motor component of the median nerve, will supply the flexor pollicis longus and flexor digitorum profundus, enabling him to flex the thumb and index finger to make a complete OK sign. So from the screening, we know that median nerve is not involved. Then we can ask him to screen for ulnar nerve. So ulnar nerve, 2 screening is there. We can either look at the dorsal interosseous. As he does the OK sign, look at the dorsal interosseous muscle. There's no guttering, there's no wasting of the dorsal interosseous muscle. You can also ask him to abduct and adduct. Okay, and and you can ask him to ulnar deviate. Okay, and so he's able to ulnar deviate. So it is the screening is negative for ulnar nerve also. Radial nerve, we have to see if the patient can extend the MCP joint and extend the wrist. Ini boleh buat macam ni? Tak boleh. Yang ni? Yang ni? Okay, so he's not able to extend the wrist of the left hand, nor is he able to extend the fingers. Okay. So the screening is positive for radial nerve. So now we do look, feel, move special test for radial nerve injury. So on inspection, what will you inspect for? Inspect for the lateral compartment of the forearm. Lateral compartment. So these will be supplied by radial nerve. So lateral compartment is also known as the mobile ward muscles of Henry. So they comprise the brachioradialis, extensor carpi radialis longus, extensor carpi radialis brevis. So if this is wasted, just see, inspect, see if there's any flattening. So we can note that there is some wasting on the left, okay, brachioradialis. Then inspect for the elbow with adequate exposure. Ask him to fully abduct the shoulders. Okay. So what can you see? There's a hypertrophic scar at the linear hypertrophic scar at the anterior medial aspect of the left arm. There's no deformity, no swelling, no cubitus varus, no gunstock deformity at the elbow joint. Ask him to flex. Look at the posterior aspect. Okay. Besides a hyperpigmented lesion, there's no eventful finding. Okay. Then we have to also inspect for the triceps. Triceps, to look for any wasting of the triceps. On inspection, the triceps doesn't seem to be wasted. Look is done. Then palpation. In peripheral nerve, it's very simple. Just palpate for the muscles which you inspected for. So we palpate for the brachioradialis. So from consistency, if it is firm, it is not wasted. If it is soft, it is wasted. Firm is similar to palpating your nasal cavity. Okay. Soft is similar to palpating your lips. So they can feel firm consistency on the right lateral compartment, but it is soft on the left. Then I also palpate for the triceps. Triceps is firm bilateral. Look, feel, then movement. So movement is important because through movement we can identify the level of the lesion. So in radial nerve injury, there's 3 levels of lesion. Low level lesion is indicated by the injury at elbow. Means if the radial nerve is actually cut at the level of the elbow. High level means at the humerus, level of the humerus. There's a radial groove in which the radial nerve passes through. So if the radial nerve is injured at that level, it results in a high level lesion. If the radial nerve is injured at the level of the axilla, it is a very high level lesion, as evidenced in Saturday night palsy. So just remember this rule: finger drop, wrist drop, elbow extensor weakness. So if there's only finger drop, it is low level lesion. If there's finger drop and wrist drop, high level lesion. If there's finger drop, wrist drop, and inability to extend the elbow, I can't extend the elbow, that is very high level lesion. So we are going to screen for that. So I would like to just immobilize each joint to only test for the specific movement. Okay, boleh luruskan jari. So he's not able to extend the fingers on the left hip. Okay, this finger drop happens because of posterior interosseous nerve injury. So in low level lesion, you will only get finger drop due to injury to posterior interosseous, called posterior interosseous nerve syndrome. PIN, it's a branch of radial nerve. Then I want to check for wrist drop. So I immobilize the wrist and then I ask him to boleh yang ni macam ni. Okay. So there is limited extension over the wrist joint. Then I want to check for elbow extension. How will I check for elbow extension? Instead of just asking him to extend elbow, I will ask him to push the elbow against resistance, because I want to obliterate the effect of gravity. Because if I just ask him to extend, he can simply drop. He might not even use the triceps to actually extend the elbow. He might just leave gravity to do its work, and that wouldn't give an accurate picture. So the muscle power is, elbow extension is 5 out of 5. So here he has finger drop, wrist drop, and normal elbow extensor. Here, so your what is your provisional diagnosis? The level of lesion? High level, so mid-shaft humerus. How will I confirm this? I can do a special test to check for sensation. So for radial nerve, the spot I want to check is the anatomical snuff box. Okay, anatomical snuff box. So if the sensation is intact, it's a low level lesion. Sensation is absent, it's a high or very high level lesion. So we are going to just test. Yang ni boleh rasa? Yang ni? Sama ke kurang?
Dia kebas.
Sini kebas. So you see that there's numbness here. Yang ni tak kebas. Yang ni kebas. So there's numbness. So this confirms that it's a high or very high level lesion. And based on the movement, he's able to fully extend the elbow, but he has finger drop and wrist drop, so it's a high level lesion. And as we are right, he actually had a mid-shaft humerus fracture, which is resulting in the high level radial nerve injury.